First of all, now Dr. Victor is trying to share his screen. First of all, thank you, Dr. Ahmed, for this nice preparation, and for this activities. And I am glad to welcome all members and all present here in this lecture or in this meeting. And I am welcoming Dr. Victor Hugu, which is a well-known name, a big name, that he will share us his lecture about the subject, difficult subject, as he told us, and as we know, all of us, about the major ascending and descending tracts in the brainstem. The problem of the language, I think all of us are the mother language is not English, and it is not a big problem for all. And you are well known in the introduction of this lectures everywhere. This activities prepared by Dr. Ahmed Al-Jaradi, our representative from the Yemeni Neurosurgical Society, with WFNS Neurosurgery Forum, and the Pakistan Society of Neurosurgeons, and the Neurosurgery Couch and Neurosurgical TV. I am very happy to introduce Dr. Victor. And all of us will be, inshallah, it is a good benefit for all of us. Dr. Victor, are you here? Professor Victor?
Yes, of course.
You are welcome, and we are very happy to see you and to listen to you and see this your nice, difficult lecture about the tracts, ascending and descending through the brainstem. And we can start. Dr. Naufal is present also. Dr. Naufal Al-Ashhab is the moderator of this presentation. Dr. Naufal.
Hello everyone, you can hear us in this picture by Dr. Victor. It's a very important subject about important ascending and descending tract in the brainstem, and we welcome for everyone. And
thank you, Dr. Naufal. Dr. Victor, we can start, please, with great thanks.
Thank you so much. I feel very happy because of this honored invitation to present this lecture. Let me put my screen. Can you see the whole screen?
Yes, Professor.
Now, yes.
Okay. So now is okay, whole screen?
It's coming and going. Now is okay.
Is okay?
Yeah, it's okay. Start, please.
Whole screen.
Yeah.
Okay, thank you.
Thank you.
Okay, let's go to talk about this interesting and also difficult theme to treat. I'm going to talk about major ascending and descending tracts in the brainstem. Thank you to Yemeni Neurosurgical Society and WFNS. This is Victor Hugo Perez from Mexico City. I am brain surgeon, and I have been doing investigation and research in vascular anatomy of the central nervous system in Mexico City. So, pathway for kinesthesia and discriminative touch. First of all, I'm going to talk about the sensitive tracts, and then after the motor tracts. These fibers are coming from the posterior column and then ascend ipsilaterally to their side of entry into the spinal cord and synapse in the gracile and cuneate nuclei in the medulla oblongata. In the right side, I have a scheme to show these kind of tracts. They are in my native language, in Spanish, but these names are also the name in other languages. So second order fibers from the gracile and cuneate nuclei cross in the medial oblongata, lemniscal and sensory decussation to form the medial lemniscus system. The medial lemniscal fibers terminate on neurons in the ventral posterior lateral nucleus of the thalamus. So this is a nice and beautiful picture about a parasagittal cut of the brain. This was work in a special staining. Its name is Mulligan staining, and this is very special because we can transform the gray substance into the blue color, and in white color we have other especially white fibers. For example, here we can go to the anterior nucleus of thalamus with the number 1. This is the thalamus. We have also head of caudate nucleus, the cuneus, calcarine sulcus, the globose nucleus in the cerebellum. Here we have it, and the medial lemniscus. This is a very interesting picture in which we can see the medial lemniscus. We can differentiate these white fibers with this Mulligan staining. The red nucleus with the number 8 is in the midbrain, and substantia nigra with the number 9. Let's go to the next slide. The fibers of the gracile and cuneate fascicles project to neurons in the nuclei of the posterior column of the medulla oblongata, gracile and cuneate nuclei. The axons of neurons in the posterior column nuclei, second-order neurons, internal arcuate fibers, decussate in the tegmentum of the medulla oblongata, sensory lemniscal decussation, to form the medial lemniscus, which ascends through the medulla oblongata, pons, and midbrain to terminate in neurons of the ventral posterolateral nucleus of the thalamus. The axons of neurons in this thalamic nucleus are named third-order neurons. This thalamic nucleus send fibers that project to the terminal station of this pathway in the somesthetic primary sensory cortex of the parietal lobe. In these pictures, we have the lateral aspect of the brain, the left lateral aspect, and we can differentiate very well the central scissor, the precentral scissor, and here we have the parietal lobe. This is the site where these fibers project from the thalamus, from the ventral posterior lateral nuclei. So the clinical manifestations in lesions in the posterior column medial lemniscus. First of all, we have inability to identify the position of a limb in space with their eyes closed. These patients cannot tell whether a joint is in a flexion or extension position. Number 2, inability to identify objects placed in their hands, such as keys and coins, by their shape, size, and texture with their eyes closed. Loss of two-point discrimination. These individuals cannot recognize two stimuli applied simultaneously to the skin when the latter are separated by the minimum distance necessary for proper identification. Inability to perceive vibration when a vibrating turning fork is applied to a bony prominence. And the last, inability to maintain a fixed upright posture when the eyes are closed and the feet are placed together. This is known as Romberg test. These individuals begin to lean sideways and may fall when they close their eyes, which eliminates visual compensation. Here we have a picture in the frontal lobe. This is a coronal view, and we can see the complex formation of the white fibers. As you can see here, this is the corpus callosum, and here we have the corona radiata, and we can see also the anterior cerebral arteries and the third ventricle. This is the caudate nuclei, and here we have the plexus choroid, the choroid plexus in this side. So here we have the midbrain. So let's go to the next. Pathways for unconscious proprioception. Non-conscious proprioception is mediated by two spinocerebellar tracts. Here we have this is named as posterior spinocerebellar tract. This tract conveys impulses from the muscular spindle and the Golgi tendon organ. These impulses travel via nerve fiber groups 1A, 1B, and 2. They enter the spinal cord in the dorsolateral portion of large diameter. As you can see in this scheme, the fibers of this posterior spinocerebellar tract. So they enter the spinal cord in the dorsolateral portion of large diameter, thickly myelinated, large diameter fiber portion of the posterior root, and project to the ipsilateral nucleus dorsalis, named as Clark's nucleus, and the accessory cuneate nucleus. These axons in the dorsal nucleus are named second-order neurons and form the posterior spinocerebellar fasciculus, which ascends in the lateral funiculus and the spinal cord and the medulla oblongata to reach the cerebellum via the inferior cerebellar peduncle. This is also known as restiform body. So the axons of neurons in the accessory cuneate nucleus from the cuneo-cerebellar fasciculus, which reaches the cerebellum via the restiform body. The information relayed to the cerebellum via the posterior spinocerebellar fasciculus and the cuneo-cerebellar fasciculus, including the phase, the rate, and the strength of the contraction. Here we have the scheme related to this interesting posterior spinocerebellar tract. So the anterior spinocerebellar tract is the anterior ventral tract conducts impulses from the Golgi tendon organ through the 1B afferent pathways. Here we have the organ of Golgi, the Golgi tendon organ, and the afferent fibers project to neurons in the posterior horn of the spinal cord, laminae 5 to 7. And then the axons of neurons in these laminae decussate toward the contralateral funiculus to form the anterior spinocerebellar tract, which ascends through the spinal cord, medulla oblongata, and pons. Some loops return to join the superior cerebellar peduncle, that is also known as brachium conjunctivum, and enter the cerebellum. The anterior spinocerebellar tract carries information related to interneuronal activity and the effectiveness of descending pathways to the cerebellum. Lesions in the spinocerebellar pathways, such as hereditary spinocerebellar degeneration, result in uncoordinated movement. These patients tend to walk with a wide base, stagger, and frequently fall. The trigeminal pathways convey exteroceptive and proprioceptive sensations from the face to the thalamus. Therefore, they correspond to the spinothalamic and posterior column medial lemniscus pathways, which transmit similar sensations from the rest of the body. Exteroceptive pathways are somatic sensory fibers that propagate sensations of pain, temperature, and touch from the face and the anterior surface of the head. The neurons of origins are located in the semilunar Gasserian ganglion. The pathway for pain and temperature. The small diameter unmyelinated fibers, C and A delta fibers, convey pain and thermal sensations and enter the spinal cord via the contralateral division of the dorsal posterior root. As you can see in this scheme, we have the receptors of term and pain, and then crosses to the spinal cord, and they ascend in this way until the ventral posterior lateral nuclei, and then to the sensitive area of the brain. So they ascend one or two segments and project to neurons in several laminae, 1 to 6 in the dorsal cord. Axon cross in the anterior white commissure and form the lateral spinothalamic tract in the lateral funiculus. The spinothalamic tract ascends through the spinal cord and brainstem to project to neurons in the ventral posterior lateral nucleus of the thalamus. The axons of these neurons project to the somesthetic cortex via the posterior segment of the internal capsule. The major motor pathways. This is very well known as corticospinal or pyramidal tract. The most important of the descending tracts is the corticospinal tract. It arises primarily from the motor area 4 and premotor area 6 cortices, passing through the internal capsule, the cerebellar peduncle, the cerebral peduncle, the base of the pons, and the pyramid of the medulla oblongata. In the caudal medulla oblongata, approximately 75 to 90% of these fibers decussate to the motor of pyramidal decussation to form the lateral corticospinal tract in the lateral funiculus of the spinal cord. About 80% of the pyramidal fibers remain uncrossed and form the anterior corticospinal tract, named also as Tork's bundle, in the anterior funiculus of the spinal cord. So the fibers of the pyramidal tract influence alpha motor neurons either directly or through interneurons that facilitate flexor motor neurons and inhibit extensor motor neurons. The fibers of the lateral corticospinal tract terminate on motor neurons in the lateral part of the ventral horn that innervate the distal limb muscles. The fibers of the anterior corticospinal tract terminate on motor neurons in the medial part of the ventral horn that innervate the neck, trunk, and proximal limb muscles. So I want to show you this video. I think this is very interesting because, as a matter of fact, when I was doing some dissection, I was trying to see the corticospinal tract, and I was very impressed to see the decussation of this beautiful tract. So I had this brain, and I made a coronal cut and superficial cut in the anterior surface of the brainstem, and then I localized this corticospinal tract. I am following him with this marker, and then we can see the crossing of the fibers of this corticospinal tract. And look at this. This is really, really interesting. So here we have decussation. Most of the fibers, as you can see, from here to here, decussate, and only less, maybe 10–15% of these fibers do not decussate to the other side and form the anterior corticospinal tract. So because I consider that this video is really interesting to see the corticospinal tract, I want to repeat it. So here we have the pons. This is the trajectory of the corticospinal tract in the pons, and then goes to the medulla oblongata, and then the pyramid. Then these fibers crosses to the other side of the spinal cord. So here we have several things to talk about this interesting video. For example, in here you can see in color red some branches that are coming from the anterior spinal artery. As you know, this anterior spinal artery arises from the vertebral arteries, sometimes just one anterior spinal artery, and sometimes two or three coming from both vertebral arteries. And look at this, these arteries are going to the corticospinal tract. So, as I told you, I was very, very impressed to see this tract. Here we have another interesting picture. What I am doing now is following arteries to go to the white fibers, and in that form, in that way, we can understand much better the zone of irrigation of these arteries. So here we can see the posterior cerebral artery, then the the superior cerebellar artery, and here I am displacing the hippocampus. Here we have the hippocampus, and I think this picture is very nice to show the irrigation of this part of the brain. Lesion in this tract, in the corticospinal tract, cause paralysis. If the lesion is located above the level of the motor decussation, the paralysis is contralateral to the site of the lesion. In abnormalities of the pyramidal tract below the decussation, the paralysis is ipsilateral to the site of the lesion. In addition to paralysis, lesions in the corticospinal tract result in a set of neurological signs that include spasticity, hyperactive stretch reflexes, hyperreflexia. This is known as hyperreflexia, Babinski signs, and clonus. Collectively, this group of manifestation is known as upper motor neuron signs. The corticopontocerebellar fascicular. This is another motor tract. This constitutes the largest component of the descending fiber system of cortical origin. It is estimated to contain about 19 million fibers, in contrast to the pyramidal tract, which includes about 1 million. The fasciculus originates in wide areas of the cerebral cortex, but primarily in the primary sensory and motor cortices of the cortex. It also descends on the internal capsule, the cerebral peduncle, and the base of the pons, from which these fibers project to the pontine nuclei, as you can see in here. Here is the pons, and here we have these neurons of second order that later crosses to the contralateral side of the base of the pons, enter the middle cerebellar peduncle, the brachium pontis, and project to the cerebellum. Lesions of the corticopontocerebellar pathway cause ataxia. The later, when it occurs contralaterally to the involvement of the frontal or temporal lobes, is explained by interruption of the corticopontine pathway. This is brachium pontis. The corticobulbar fasciculus. This originates in the facial areas of the cerebral cortex. It descends in the genu of the internal capsule, the cerebral peduncle, where it occupies a dorsolateral corner of the corticospinal segment of the peduncle and a small area medial to the base of the peduncle. The base of the pons where it intermingles with corticospinal fibers. And the pyramid, but without reaching the spinal cord. At different levels of the neurexis, it projects to cranial nerve nuclei. Some corticobulbar fibers project directly to cranial nerve nuclei, trigeminal, facial, and hypoglossal. However, most project to reticular nuclei before reaching cranial nerve nuclei. This system is known as the corticobulbar fasciculus. So here, this is just, I want to show you this slide just to show the sagittal aspect of the brainstem with the corpus callosum, genus, body, the thalamus, the corpus callosum, and the lateral ventricle. What I have told you is now I am doing some dissections of white fibers, and this work is very, very interesting. In advance of this white matter dissection, here we can see some fibers of the cingulum. Here we have the dissection. I removed the gray substance, and then I'm going to show you in the next. So we can see here the cingulum, we can see the caudate nuclei, and also the fornix. So here we have the pineal gland, the midbrain, the thalamus, midbrain, and pons. So other corticofugal tracts, these are the corticothalamic, corticostriatal, and corticohypothalamic tracts, which serve as feedback mechanisms from the cortex to these sites. Corticothalamic fibers originate from cortical areas that receive thalamic projections and descend in the internal capsule. They enter the thalamus via the thalamic radiation, which includes reciprocal thalamocortical fibers. Then we have the corticostriatal fibers, can be direct or indirect. Direct corticostriatal projections reach neostratum through the internal and external capsules. Indirect corticostriatal pathways include the corticothalamo-striatal and collaterals of the cortico-olivary and corticopontine pathways. And the later is the corticohypothalamic fibers that arise from the prefrontal cortex, cingulate gyrus, olfactory cortex, hippocampus, and septal area, reaching the hypothalamus via the internal capsula. So here we have the hypothalamus, and here we have the optic chiasma and the anterior commissure. So let's go to next. Subcortical origin arise from the midbrain, pons, and medulla oblongata. From the brain, the major motor pathway of the midbrain is the rubrospinal tract. This tract originates from neurons in the caudal magnocellular part of the red nucleus, crosses the ventral tegmental decussation of the midbrain, and descends in the midbrain, the pons, the medulla oblongata, and the spinal cord, where it occupies a position in the lateral funiculus very close to the lateral corticospinal tract. The rubrospinal tract is considered an indirect corticospinal tract. The rubrospinal tract facilitates flexor motor neurons and inhibits the extensor motor neurons. In almost all mammals, the rubrospinal tract is the main output of the red nucleus. With evolution, the red nucleus output to the spinal cord decreases, and in humans, the main output of the red nucleus runs to the inferior olive, which in turn projects to the cerebellum. So this is another interesting picture to see a staining, Mulligan staining, to differentiate the white substance to the gray substance. White substance is in this color, and gray substance turns to a blue, to a soft blue color. So here we can see the peduncles of the midbrain, and we can see the parts of the tegmentum, the tectum, and the parts of the midbrain. So this is also a dissection, white fibers dissection, to see the components and structure of the white fibers. Again, this picture. So this is a very interesting picture about the corpus callosum. Look, the white fibers, and they are really amazing anatomical formation. So when you make a dissection of some brain, it's not difficult. I know that in many countries around the world, it's not easy to make dissections. Also in Mexico, it's not easy. We have to get a special permission and I have been working brains since almost 35 years ago. But I want to tell you something. You can work in, for example, in a pig brains, and you can put it in formaldehyde or formal solution at a concentration of 10%, and then you can work with the brain that is similar to the human brain. Also, you can study anatomy with the cow brain. A cow brain is very good to work also with this kind of staining. In fact, this kind of staining that its name is Mulligan is the author, the investigator that made this staining. He studied the brains, the cow brains. So this is the reason I can tell you that it's not difficult to work with dissection of fibers, because we can do that in mammals' brains. So in the pons, the major motor pathways originating from the pons are the lateral and medial vestibulospinal tracts and the pontine reticulospinal tract. The lateral vestibulospinal tract originates in the lateral vestibular nucleus and descends ipsilaterally in the pons, medulla oblongata, and spinal cord, where it occupies a position in the lateral funiculus and terminates in interneurons in laminae 7 and 8, with some direct terminations on dendrites of alpha motor neurons in the same lamina. The lateral vestibulospinal tract facilitates extensor motor neurons and inhibits flexor motor neurons. So, for example, if you make some dissection, as I told you, is not only with human brains, also with pig, cow, or other big mammals. You can do these dissections, and also the preparation. The Mulligan staining was published, and it appears in several articles in the international bibliography. So here we have a axial cut of the brain. Here we have the cerebellum, and here both temporal lobes, and here we have the pons. So this is the brachium conjunctivum. So if you try to differentiate the gray substance with the white substance, yes, you can do that, but it's not a good vision to see this. For example, if we need to see the arteries, we can see them very well. For example, here we have some penetrating small branches from the basilar artery, and here we have another artery. Probably this coming from the superior cerebellar artery. But let's go to see what is the difference between a non-stained cut and with a stained cut, like in this. Look, this is really, really beautiful, amazing what you can do with this staining. So here we have the pons, here we have the brachium conjunctivum, and here we have the dentate nuclei in the cerebellum. Let's go in the initial slide. Look at this, and then this is the same in the other, but that was stained. In this case, is the result of the mulligan staining of this coat. Really beautiful. So again, we have this coat. If you work with a brain, you can dissect step by step and going for looking what you want to find. So, for example, in this case, I wanted to go to the hippocampal arteries and look at this. Here we have the hippocampus and the hippocampal artery. So really, really nice picture. Let's go to, this is a close view of these arteries. And let's go to talk about the medial vestibulospinal tract. Neurons originating from the medial vestibulospinal tract are located in the medial vestibular nucleus from the neurons of origin. Fibers join the ipsilateral and contralateral medial longitudinal fasciculus, descend in the anterior funiculus of cervical spinal cord segments, and terminate in neurons of lamina 7 and 8, and they have a facilitatory effect on flexor motor neurons. The pontine reticulospinal tract. This tract originates primarily in the medial growth of pontine reticular nuclei, caudal and buccal pontine reticular nuclei. Descends primarily ipsilaterally through the pons and medulla oblongata and occupies a position in the anterior funiculus of the spinal cord. It stimulates extensor motor neurons and inhibits flexor motor neurons. And the medulla oblongata, the major descending pathway of the medulla oblongata is the medullary reticulospinal tract. It arises primarily from the medial, central group of medullary reticular nuclei, giant reticular nucleus, descends primarily ipsilaterally to its site of origin and occupies a position in the lateral funiculus of the spinal cord. It also supplies flexor motor neurons and inhibits extensor motor neurons. I showed you this slide before, but look at this. We can differentiate the anterior nuclei of the thalamus, the red nucleus in the midbrain. Here we have the medial lemniscus, and here we have the superior cerebellar peduncle and the corticospinal tracts, the pyramidal tracts. And then here we have the cingulum. Here we have fibers of cingulum in here. And this is the head of the caudate nucleus. So as you see, it's really, really interesting to make this kind of staining. And here we have the components of this slide. So another picture about this, for example, if you look at this axial cut of the brain, so we can see several anatomical structures, but if we stain them, so we can see much better these structures. For example, here we have the head of the caudate nucleus, the external capsule, the internal capsule, and here we have the putamen, the pallidum, and here we have the striate corpus of the thalamus here, the striate corpus. So, and then the choroid plexus. Here we have the splenium of the corpus callosum. So let's go to see what happened with the staining. It's really beautiful. So here we have several structures. For example, the posterior limb of internal capsule. Here we have the internal capsule. The anterior limb in this place, the putamen with the number 9, and head of caudate nucleus with number 10, and the column of fornix in this place. So let's go. I just want to tell you something. What I have shown is just a summary. The tracts of the central nervous system are very complex, very difficult to understand. And first of all, what you need to do and that we need to do is study with passion the neuroanatomy. And if we want to understand very well this, we have to repeat, and repeat them until have a good understanding of these structures. So I think most of us have done this kind of work. So we are passionate with neuroanatomy. So thank you so much. As I told you in the beginning of the lecture, this topic is not easy. We need to have too many schemes, too many pictures. We have also to repeat them, not only reading, because doing some paintings. And I think with sometimes we are able to understand the beautiful brain. Thank you so much.
Thank you very much, Professor Victor, for this very nice presentation.
Thank you. Excuse me. Sorry. This is another coronal cut of the brain. And here we have corpus callosum, the putamen, the pallidus corpus. Here we have the external capsule. And look at this. This is also really enjoyable, really beautiful to see the corticospinal tract, the pyramidal tract, going through the internal capsule, and then go to the pons in this case. And here we have to the midbrain, and then here we have the uncus and the hippocampus. Look at this beautiful structure in the brain of all human beings. Now I think it is the end with this close view of this tract. Thank you so much, dear friends, and I am very happy to be with you. So, sincerely, thanks.
Thank you very much, Professor, and it's our honor and pleasure to have you with us. And you are one of the best neuroanatomists that I have ever known. And we all enjoy your presentations and these nice dissections and images. Thank you very much. Dr. Mujahid, Are you with us?
Dr. Ahmed, thank you. Thank you, Professor Victor Hugo, for this interesting, difficult, and very important subject, which is very difficult for the students and for all. But it is very interesting and very important, with nice presentation and also clear language. And I hope that we will start the discussion and questions from the audience and all colleagues here. If anybody want to ask, what is the Dr. Nofal, the moderator?
Dr. Nopal, I think he has some issues. He will not be able to join.
Phone calls, huh?
So if there is any questions from the audience, please, you can put in the chat, or you can raise your hand and ask directly.
I think the most important thing is the discussion and questions that will be communicable subject. It's difficult to ask.
Yes. I see in the chat there is all congratulations for Dr. Victor, and thanks for this nice presentation.
Yeah.
And always in anatomy, there is no much questions
Discussions,
from the audience, yes, usually. And the subject is really interesting. And as Dr. Victor said before, and you said, it's a very difficult subject. So I think much of the audience here will review this lecture many times to understand this information that's given by Dr. Victor. Okay. Dr. Narjiza, do you have any question or any remarks? Dr. Simon?
Thank you so much. It was a great presentation with clinical explanations as well. Thank you, Professor Hugo. And I think we all have to understand that from all over the world, we have good experts, and professors from Mexico is performing the great dissection. And I personally would love to come and see your dissections, because what I was listening, I was taking a few photos as well. So it's difficult to understand, like it was mentioned, but it requires time. So thank you so much.
Thank you. Thank you so much, Professor Nargisa. Yes, as I told you, it's not difficult to work in brain. So I think in most of the country, we can get a brain of some big mammal. I also know that in some countries, it's not allowed to have a brain of mammals. But maybe in one kind of mammal, you can make this dissection. It's really impressive to go to these stainings, and when you work with a book of with anatomy book, when
Not visible,
okay.
but got it. Yes.
When you look in the book, maybe it's difficult to understand. But then if you look to several paintings, drawings, and then to go to dissection, oh, this
I'm very clear, yes.
is a very nice experience. So thank you for your comment.
And it's also hard work, because it requires time to dissect, to take photo, to find the better light and so on, so that you can present us. And for us, it looks easy, but behind that, it's a big hard working stuff. Thank you so much.
Think so. Yes, thank you.
So thank you, Victor, and it really will have a great pleasure if you can have a visit and try to visit your neuroanatomy lab and to see some of these dissection live. It will be a great opportunity to all of us.
Thank you so much. Thank you.
So I think Dr. Mujahid, if there's no questions, if you can say the final words to conclude the session.
Okay, great. Thanks for Professor Prof. Victor Hugu for this interesting and very important and very difficult subject regarding the tracts. And we hope so that all of us want to join him in his lab to see this hard-working dissection. Great thanks, Dr. Ahmed, for this nice preparation and continuous medical education for all of us, either juniors or seniors. And thanks for all participating persons and colleagues here in this lecture or presentation. And thanks for everybody. Thanks, Dr. Ahmed again, Professor Victor Hugo, and all. I hope, inshallah, we will meet next Friday for the new subject. Thank you again. We are very happy to do that and to continue in these subjects every Friday.
Thank you, everyone, and see you all, inshallah. Thank you, everyone, and see you all, inshallah, next week and next Friday with more speakers and with more subjects. And thanks again to Professor Victor for this very nice presentation. It's our pleasure. So see you all, inshallah, next week, inshallah. Goodbye.
شكرا للجميع.
Thank you.